It's ReeferMEDness, the podcast, with Trevor and Kirk.
Hey, how's it going, Trevor?
Kirk, I'm doing really well. I'm annoyed at you, though.
You're annoyed with me.
I am. You and Dr. Terplan interrupted a really nice cycle around Saskatoon. Saskatoon has some really nice bike trails all up and down the river.
Right.
And I was listening to this interview while doing that. My daughter's going to school there. We were looking for an apartment, yada, yada. But I was going for a bike ride in the morning. Beautiful bike ride, beautiful trails, and I had to stop like every 5 minutes to mark down some really interesting stuff you guys were talking about.
It was
so a bike ride interrupted.
Yeah, it was. I listened to the interview again today, and it really got into a nice discussion and a very long goodbye. I mean, I almost like I had a second interview as I was saying goodbye to him.
Well, I was just amazed with, so here's a guy who goes off, becomes an OBGYN, and then gets into addictions medicine, and then gets into cannabis, we'll call it advocacy, and you are looking for doing a series of things on pregnancy and cannabis, so hard to find a better person.
Yeah, no kidding, right? No kidding. How do you not get a better qualified person to talk to us? And again, you've said this over and over again, how amazing it is that people return our phone calls. I mean, I think it's fantastic. And then when you start talking to these people, I have a little simple question. Can you tell me about cannabis and pregnancy? And I'm talking to a man of that caliber. And yeah, I really liked the interview. I love the way he talked about cannabis as an old medicine and how cannabis was mostly a female medicine. And
I had no idea.
Yeah. Well, as he was saying it, I said to myself, I've seen that over and over again. You and I are working on a course for how to live well with cannabis, aging well with cannabis, and in that research for that course we're going to teach, I was noticing how every time I got into the old cannabis use, female health is there. Menstrual cramps. Cleopatra apparently used it. Queen Victoria apparently used it. So, I mean, cannabis has been used by women for a millennium. And here we've got an OBGYN that gets that. So I don't want to give too much away, but I think this is like step 2 in your many-part series in tracking down things from the Jamaican study, because it came up again. I'm gonna eventually talk to Dr. Dreyer. That study, I was talking about that study, I'm sure, in episode 0. In episode 1, I was talking about that study. I found that study years ago and never. So yes, someday I think we'll probably get to talk to her. There's also the other thing we should remember to acknowledge, Trevor, that once again, we're two men interviewing another man about female health.
Yes. So obviously we are doing it sort of a step removed from people who actually experience things like pregnancy and childbirth.
Yes, we are, as researchers and question askers. But I want to start this. This is the second of a series of episodes I want to do with maternal health and mom and baby and cannabis. So I want to preface this by saying, as a nurse, as a human being, I understand that women have choices and it's a woman's body. As a nurse, I'm very concerned about the prenatal patient for the life of the baby, right? So there's two patients in this, and there's always society's debate about the right of the unborn child. I do not want to get into that in this episode, except to say, as a nurse, public health nurse with community health experience and practice, caring for the unborn child is part of my responsibility. So understanding how cannabis affects a prenatal mom, a woman, it's almost redundant to say a prenatal woman or a pregnant woman, right? A pregnancy. I want to understand it because I've seen it, I practiced it, I've had patients come in under the influence of alcohol and under the influence of other drugs and cannabis as prenatal patients. So be damned if I did not chat with a man who's probably a top expert in America for what he does. You know, addictions, OBGYN. So I want to preface the conversation by saying that, right? It's ladies have a right, but it's the unborn child. So does cannabis affect the unborn child, Trevor?
Let's listen to someone much smarter than us talk about that.
Well,
let's go to Dr. Terplan.
Okay, let's do that, because let's listen to it. It's a good story.
It is.
Thank you for having me. My name is Mishka Terplan. I'm a physician. I am trained as an obstetrician gynecologist and also an addiction medicine provider. So my work really has been along the intersections of reproductive and behavioral health, which includes, taking care of people who are pregnant who use drugs. I'm currently the associate medical director of a drug research think tank and adjunct faculty at University of California, San Francisco, where I'm a clinician on their National Clinical Consultation Substance Use Warm Line.
Perfect. So you've specialized in obviously women's health, babies, delivering babies, and addictions. So those are the three branches of your practice.
Yeah, I would say that is where my interest in practice began, but as time has gone on, I spend almost now no time on labor and delivery, a little bit of footprint still in prenatal care, but most of my clinical research advocacy work it's centered around more, I would say, reproductive health rather than pregnancy specifically, and more in addiction medicine than in OBGYN. So clinically, I do, for the last, at least 5 years, also see men and take care of people with addiction medicine, in addition to, women with substance use, misuse, addiction, et cetera.
Okay, so we have you on this interview because of your understanding of cannabis as a substance of addiction and its relation to prenatal health.
Yes.
Perfect. Okay. Let's start from there, sir. From the very beginning, when did this interest come to you? When did you decide, hey, I'd like to study people's addictions and how it relates to maternal health?
Well, I think it was really interested in both and then bringing those worlds together. So when I was a medical student, I worked, volunteered in a syringe exchange. I set up a clinic for, people who were homeless and people who were using drugs. And a lot of that was just out of real interest and connection in working with people who use drugs. Then as a student, turned out I really liked obstetrics and gynecology. And so I went and did my residency in that. And really my career as a resident and certainly thereafter was about bringing those two worlds together. How can I bring the world of substance use in alignment with my specific training in OBGYN? And so that began historically, as I mentioned, in working on pregnancy. But as time has gone on, it's been about a lot more about thinking about, sexual and reproductive health as they relate to recovery, and thinking about how we can sort of integrate better, substance assessment, so to speak, in reproductive health care.
You are a medical doctor. Have you formalized your education with a master's or a PhD as well?
Yeah, I have after my residency, so in the United States medical school, followed by residency, I did a fellowship in clinical trials and epidemiology. As part of that, I got a master's in public health.
Okay, so you are a trained researcher, not just as a physician. So can you talk to me about some of the research you've done with addictions and I guess specifically with cannabis?
Yeah, so one of the things, I think the original stuff we've done has been somewhat descriptive. In particular, looking at both self-report and urine drug test results during prenatal care, and looking at the number of people and et cetera who tested positive for cannabis at a period, and looking at how that changed over time. And so some of the early stuff that we looked at, we demonstrated that one, cannabis was actually the most common substance reported at the first prenatal visit, more common than tobacco, which by national population health data is the most common substance during pregnancy. And then the second thing we documented was that most people, in fact, almost everybody, decreased use through the course of pregnancy. And amongst the almost 30% of people who, had use in early pregnancy, there was less than 1% who were still using at the time of delivery. So for me, those data sort of support the statement that, all people who are pregnant are motivated to maximize their health, the health of their baby. People engage in behavioral change during pregnancy. And one common thing is people quit or cut back, substance use, inclusive of cannabis.
Now, these would be women that are actually receiving prenatal care, so they're getting the counseling
Correct.
that encourages them to do this. Do you have any data that suggests without counseling, behaviors remain the same, I guess? Or I guess the question is, through counseling, there's an expectation of behaviors change, and you're finding that.
Yeah, you're sort of asking about the role of screening and brief intervention to some extent. So this clinic is somewhat unique in that it, me and other people have set up a system of, as being as welcoming as possible for everybody who walks in through the door, and assessments are a routine part of care. So it may or may not be representative of every single prenatal practice that exists. But the brief intervention piece, honestly, the counseling was minimal, and certainly not protocol or manualized or anything like that. So I interpret these data as less about the clinic and more about the patients, the people, and their behavior change. That being said, the data for brief interventions, or actually many forms of counseling in reducing substance use in general, much less in pregnancy, is just not there. We see expert working to some extent for alcohol-related emergency department visits, but we don't see it really working for other substance use. And in pregnancy, we have no data don't support any psychosocial interventions, but that's not because they might not work. It's because that natural history of change that I mentioned, most people quitting or cutting back, if you have to show an intervention that's greater than that, is very, very difficult.
Okay. All right. So let's focus on cannabis then. What have you learned about cannabis in your studies and your observations?
Well, to me, cannabis is, sometimes I say endlessly fascinating. In particular around women's health and pregnancy. Historically, I know you know this, like every single cultural pharmacopoeia, it lists cannabis as a medicine, and many of the utilizations relate directly to women's health. There are, archaeological evidence of obstructed labor, where, cannabinoids or, either, seeds, or it's unclear exactly how the cannabinoids were used. It appears from the archaeological record, for that. And then, around the turn of the 20th century, the period of the so-called patent medicines, cannabinoids were, sold under multiple different formulations with a focus on women's health. They were prescribed for menstrual irregularities, ovarian pain, and et cetera, and things like this. And so there's a historical sort of pre-modern medical utilization of cannabis for women's health in general and obstetric care in particular. So that is, that is interesting. That is different, than cocaine or than opioids, although they too have a gendered component to them to some extent, in the historical record. So that's one context. The second context is this, in the United States, this changing regulatory environment that varies by state and clearly over time, where the cannabis ranges from recreational legalized at the state level to punitive completely across the board, or these sort of hybrid medical, of which there's multiple different types. There's medical cannabis that, is only CBD, and there's medical cannabis that allows for, THC and edibles. And so there's a hugely, like heterogeneous environment. And women are clearly like getting pregnant and staying pregnant, across these different states and stuff. And despite this sort of loosening and liberalization of cannabis policy, it still is, at the state level, and in particular in the world of child welfare, something that when people test positive for, child welfare does get involved. And one thing I didn't mention in the introduction is the work I've done with sort of legal groups and legal advocacy organizations around child welfare and substance use and pregnancy in particular. And I just keep seeing cases where, people test positive for cannabis, and the state begins, foster care placement and child removal, processes. So that is unique.
Yeah, no, that. I like the fact that how you phrase that we have cannabis in Western medicine in the 1800s. We have cannabis in European and Asian medicine thousands of years ago, and it's only been the last 60 or 70 years ago that cannabis became bad. So but yet we still have cannabis in our population. In Canada, as you know, Canada, it's legal and national. I know that your country is very jurisdictional with its legalization, but in your practice, you see cannabis quite readily, right? And we've identified it in Canada as probably the number one thing that pregnant women will use. Now, usually, what the average woman finds out she's pregnant halfway through or at the latter part of the first trimester, right? And then they go into prenatal care, and that's when they get some counseling. So that sort of segues me into your practice. So how have you now studied cannabis? What have you learned about cannabis specifically in your practice if the majority of the women are coming?
Yeah, so I think there's, so some of this is from my own clinical experience, some of this is from my knowledge of the published literature, and some of it is from, discussions with other providers who work in this space. To me, I think there's a couple of things that mark cannabis as sort of unique or that I would focus attention on. One is the utilization of cannabis as medication or self-medication for people who are pregnant, and what that means and what that looks like. And what these are from national data, is most people don't, when on surveys, don't say they exclusively use cannabis for medicinal purposes, but some people do. Roughly 5% of people who are pregnant, and amongst people who are pregnant and have used any cannabis, about 5% will say it's for medicinal purposes only.
And I'm sorry, is that a relatively new phenomenon in the last few years that people are identifying cannabis as medicinal use?
Great question. We don't know the answer to that, because it's only in the last 5 years or so that question has been specifically asked in national level data.
Okay.
So, but I do think that it might be increasing. Now, whether there are cynical and I think somewhat judgmental perspectives where people would say, well, women are just saying that because they can't,
Right.
But I think that's somewhat dismissive of, people's own motivations for use. But what we see is that people who, say I use cannabis medicinally only, actually don't change their use during pregnancy. They don't decrease. And that,
because they're using it as medicine.
Makes sense.
They're using it as medicine.
Yeah, exactly.
Right.
They're using it. So, The second thing that sort of, I think, unique, it relates to the issue of child welfare. So, so one thing in our clinic, so we can talk through, if you want, like to the literature on what are the sort of effects of cannabis on a pregnancy.
Yeah.
But overall, to put it very simply, like the effects are minimal, and the data are, you know, confounded by other factors such as tobacco and et cetera. And certainly when if you want to compare substances, you know, in terms of birth outcomes, alcohol, you know, is the leading cause of intellectual disability in the United States, and I would assume in Canada as well. You know, tobacco is associated with small birth, you know, low birth weight, NICU admissions, et cetera. And those quote unquote harms are far greater than those described for illegal substances. It's unclear. You know, the literature on cannabis changes over time too, in part because cannabis has changed. Maybe. So like the data from the 80s or 90s showed basically hardly any differences in terms of birth outcomes. And more recent data shows some slight differences in terms of neonatal intensive care unit admissions, anemia. I'm not sure exactly how that is. If these are associations, these aren't necessarily causal linkages. And some people say that's because, you know, the THC concentration has increased over time. But it could be, you know, that which is a plausible hypothesis, but is not established. But for me, like the thing is, go ahead.
No, well, what I'm finding in most of my reading, and you really have to read carefully, because the headline will say cannabis associated with low birth rates. But as you get into the study, you start realizing there's one little sentence that's buried in the narrative. They haven't removed the causative action of tobacco. So in all of these cases, we say that 100% of these women have had low birth rates, but 100% of these women are also smoking tobacco. And it's like, well, we know tobacco causes low birth rate. Why are we associating cannabis with that? Why is the headline cannabis causes low birth rate? And your study eliminated that, right? The one that I was looking at from, can you explain that? So what that was 2015. You were able to actually remove the cannabis from the tobacco from the equation, right?
Yeah, so I mean, I don't know. So the statistically, you can quote unquote control, you know, for tobacco smoking, and then you can see the, you know, quote unquote residual effect of the cannabis. That is that standard way of doing this, or a simple standard way of doing this sort of research. But honestly, when people do that, the data are mixed still. There's some data that still show a residual effect, and some data where when you control for it, it goes away. For this low birth weight or and I think though what we need to, it's not just the outcome, but it's also the magnitude of the effect, right? So you know, yes, you can statistically, there's some data where statistically, yes, cannabis use is associated with smaller birth weight infants, but the magnitude of the effect is about, you know, 25 or 50 grams. Now is that clinically significant? If that association is causal, is that difference clinically significant? Right. Could that difference be explained by other factors, you know? And you know, right now, most of what we're talking about is, you know, cannabis that is, you know, smoked plant product, not other formulations of, you know, cannabis or cannabinoids. So I think there's, you know, like one could design a better study that would look at, you know, cannabis as smoked, cannabis as, you know, like, you know, measured correctly and, you know, like in a more modern medical formulation, and look prospectively and, you know, like an RCT kind of situation, but we don't do those around substance exposures in pregnancy for obvious reasons. So we are left with, you know, these sort of messy, incomplete data, which lend itself to these kinds of overinterpretations that you describe.
Yeah, it's fascinating. In some studies, you know, you read that when you compare cannabis smokers with alcohol drinkers in university, you find that the cannabis smokers tend to have, 50 years on or 20 years on, they tend to have better careers. I've seen that study, but I'm looking at your study and at one of your papers, and it seemed like the cannabis was low social economics, right? That this clinic, this university clinic, it seemed
yes,
to be
yeah. Mm-hmm.
So low social economics. I mean, we know that again that has contributing factors to prenatal care, and so I guess it's the study in the cohort as much as the substances that you're studying.
Yeah, and so to kind of place this in the context of pregnancy, there are really, there's at least 4 prospective cohorts in the published literature that have followed cannabis use in pregnancy, and then for varying lengths of time followed the kids. And the first one is from the 1980s and was really more of a medical anthropology study in Jamaica, where the women drank cannabis tea, so did not use inhaled plant. And what they found was actually that the birth outcomes were better amongst the moms who drank cannabis tea compared to moms who did not drink cannabis tea. And so for various reasons that lend themselves to a bit of conspiracy theory, the person who was involved with that research actually ended up losing her National Institute of Drug Abuse funding.
That was Melody. That's Melody Dreyer, is it not? That's her study.
Yeah.
Yeah, the famous Jamaican study. I've been trying to get a hold of her. I think she's now retired, but I've been trying to.
Yes.
I've been trying to get a hold of her.
She did this remarkable research and then was lost funding, and the question and her career changed from that experience, and since then the other cohorts are larger, they're a little bit more robust statistically and etc. But don't necessarily, the magnitude of the measured outcomes when different is small. It may not be, I'm not saying it's insignificant or meaningless. I'm just saying, compared to the magnitude that we measure from legal substances, it's so-called legal substances, I know that's a changing landscape, is smaller. And that's why I think you see those headlines.
Put that in layman's term. What do you mean smaller? Like, what's the magnitude? Put that in layman's terms. What do you mean by that?
So, well, let's just look at birth weight. So, and I'm generalizing numbers to a certain extent, but cannabis birth weight change, plus or minus 25 or 50 grams. Tobacco smoke birth weight changes more towards 500 grams.
Right.
So both cause a change, and both could have a p-value that is quote unquote statistically significant. But the magnitude of the effect on the birth weight, assuming that all those things are completely solid, which they're not exactly, is a lot greater for tobacco than it is for cannabis. And so when we interpret data, we don't want to just look at was the p-value significant or not significant and say, cannabis causes low birth weight. Right. We want to say what the magnitude of the effect is. What's the effect size? Because that really guides clinical interpretation a lot more, and that relates, I think, much more towards trying to assess what the population health, outcomes are of things like this.
So in your study of the literature and from your experience, again, layman's terms, when isolating just cannabis as a substance and relating it to prenatal care, there is no significant concern. Is that the word?
I would say I would say one, we actually have a huge amount of data on this topical area. It's not like I hear oftentimes we don't really know. We actually know a lot.
Okay.
The problem is what we know is the results are mixed, right? Some showing no effect, some showing a slight positive effect. When we have a positive effect, the magnitude of the effect is relatively small compared to other substance exposures, and of sort of uncertain, sometimes uncertain significance. So So my takeaway from that whole is that that when we don't have a so alcohol is, like, for example, or even alcohol, which causes fetal alcohol syndrome and fetal alcohol spectrum disorders. We have a clear diagnosis, or clear enough diagnosis, that is causally attributed to alcohol, and that and most other substances don't have that relationship, right? And within the absence of that relationship, instead of being sort of nuanced about our interpretation and how we talk to patients and how we read the literature, we say we just don't know.
Right.
Because we're expecting it must have been illegal for a reason, and that reason must have been because it was is so harmful. Therefore, when the literature doesn't say that it's this categorical harm, we blame the literature rather than sort of think about how to think about it better.
But isn't that interesting? That's cannabis's. I mean, when you look at anything to do with cannabis, and especially from the States and the Just Say No generation, I guess my partner, Trevor, always says, well, medicine, what we do, I'm a nurse, he's a pharmacist, what we do is do no harm, right? Mm-hmm. So we know certain things. We know certain things about alcohol. We know certain things about smoking. We know that certain drugs are bad for pregnancy. Therefore, let's use a blanket statement and say no drugs during pregnancy, even though someone might use cannabis as medicine. So if you have a client that uses cannabis for nausea and she's using it throughout her pregnancy, how do you practice that? What is your clinician's approach to this?
Yeah, great question. So I think there's two things. So one is to talk about the nausea, and the second is to talk about the cannabis. So in the United States, in many places, I think it's speaking about child welfare, people are drug tested at the time of delivery. Drug tests that are positive, including for cannabinoid, cannabis metabolites, and child welfare is notified. And they may initiate an investigation, and the investigation may, culminate in, removal of the child. So I think it's very important as a provider to be, transparent about that process, and to tell pregnant people that, they may be drug tested, and these are the consequences of the drug test. I also tell them that, regardless of what happens, I will remain your advocate. I will, write letters. I will disagree with removal and with that response. So that's a very maybe more of a unique thing in the States, but I think that's very important to be transparent about what drug testing happens, what reporting is.
I don't want to cut you off. I want to. Is there a social economics issue there? Like if I show up, if I show up with a paid BMW and I'm a middle class mother and I'm using cannabis, social welfare is not going to come to my suburb and take my kid away.
So there are some examples of, middle class or upper middle class white people being caught up in the child welfare system for cannabis in particular, but overwhelmingly the people who are, reported, whose kids are removed, are poor and or people of color and or people with addiction or, sort of marginalized, quote unquote, populations of people that are, adversely affected by the criminal justice system in general. In fact, There's a lot of parallels between who gets arrested, who goes to jail, and who is reported to child welfare. In fact, there's a complete overlap between that. Yeah, and that's yet another sort of critique of that system.
Yes. Okay.
But the second thing is like the nausea. So the data on nausea are interesting. There's just a couple of studies. There's some case reports showing the sort of cannabis hyperemesis syndrome in pregnancy. There are there's population level data that showed people who use cannabis. This is both from Hawaii, the PRAMS data, as well as from Kaiser Northern California data, looking at either self-report, that'd be the PRAMS data, or toxicology, that would be the Kaiser data, and people who reported nausea and vomiting. People who use cannabis reported nausea and vomiting more. Now, I can't say that that's causal, but that's interesting. And then there are data from Canada, actually looking more. It's smaller N, and it's people who use cannabis during pregnancy because of nausea and vomiting. And those data show an improvement in nausea and vomiting, but only amongst those who were not cannabis naive. So if people, haven't taken cannabis before and take it for the first time in pregnancy, maybe it doesn't work as well as people who are familiar with cannabis. So I think that this is a long way of saying that although we know there are good data that cannabis is helpful for AIDS-related nausea, vomiting, and wasting, we don't see that the same level of benefit is not established for cannabis and nausea and vomiting in pregnancy.
Okay.
The other thing, though, is the comparison group. And this is in terms of thinking about birth outcomes or even more developmental outcomes, right? So the real concern, I think, for people who study substance exposure in pregnancy is, what does, the developing fetus and being exposed to these substances that are clearly psychoactive, what does that mean in terms of developmental outcomes? And we have, as I mentioned, there's 4 prospective cohorts looking at, children, now adults, sometimes, who had been exposed in utero to cannabis. We have no prospective data looking at developmental outcomes of children and adults who were exposed in utero to medications for the treatment of nausea and vomiting. So the proper comparison group is not comparing people who, whose mothers used cannabis during pregnancy for nausea and vomiting to everybody else. It's people who use cannabis versus people who used other prescribed medications. That's the appropriate comparison. That study has not been done, but I will say it has been funded, and there are people going to be collecting those data.
Interesting. So again, it's that whole naivety in the sense of what we know and what we don't know. We did an episode on gabapentins and discovered that in Western medicine, we always hear doctors say, we don't have enough studies. We don't have enough studies to, prescribing cannabis, we don't have enough studies. And I always bring gabapentin up. So how is it that you can prescribe gabapentin for off-label use when we don't have the studies for it? So how is it that we can justify one medication that we use off-label and we can't justify the use of cannabis? Because it's illegal, maybe? I don't know.
Yeah, so I think one is that we take, so the distinction between legal and illegal is a, social and legal distinction. It's not a biological, or even distinction. And the categories of legal, or illegal have changed, over time. Yet, we attribute greater risk and greater harm to illegal substances than we do to legal ones. Despite, preponderance of evidence, like there are very few things that are, teratogenic, i.e. cause birth defects. Alcohol does, but no other substance to which people develop addictions do. And there's a handful of medications that are prescribed and historically were prescribed, like thalidomide, et cetera, that did.
Well, we know tobacco does. We know tobacco has a trick.
Yeah, tobacco's Yeah, I mean, so the term that people, I think the term that makes the most sense to use might be like a neuroteratogen, is the
Okay.
word, so it doesn't cause a distinct like physical manifestation of birth defect,
Okay.
like a face, like, faces or, limbs or things like
Well,
that.
like the spectrum
But
of alcohol, it's a whole spectrum. Tobacco is
correct.
related to low birth rates. We know that, right?
Yeah. So whether that's a birth defect, a teratogen is like is
Okay.
is a more a specific genre of harm, and things
Okay.
can cause harms, or they can have outcomes that aren't birth defects, but that would be of the pyramid of harm. Like birth defect would be like the top of the pyramid, and then there's other stuff
Sure.
as you kind of go down. But so I think that's some of the reason why we take this social lens and apply it to medical science and public health. But when I see somebody who's using cannabis, let's say for nausea and vomiting clinically, so the couple of things. One, like, I'm an addiction medicine doctor, so I I look at everything through the lens of addiction. So I want to make sure that this person does not have a cannabis use disorder. The likelihood of them having a cannabis use disorder is somewhere probably under 10%, but it's not zero. So screening them, for whether or not they have a cannabis use disorder. The second thing is, telling them, like, as I mentioned, about what testing means in terms of child welfare. And then probably clinically, the more important thing is saying, like, is it working?
That's a good question to ask.
If it works, and then telling them what we know and what we don't know about cannabis use, and really more probably from the perspective of a question, like, do you have any questions about what, your use of cannabis might mean for the health of your pregnancy and your child to be? And, rather than, lecturing, like soliciting, that those brief those, motivational interviewing skills are central to, to clinical care.
Do you know of any studies right now? Like, are there any larger studies happening that are specific to cannabis and prenatal? Those are happening?
Yeah, there's two that I know of. One is a prospective study. I think it's out of the University of Washington, which is looking at cannabis use during pregnancy for nausea and vomiting, and will have has a big sort of a follow-up component that even involves, I think, brain imaging and stuff of newborns. And then the second one is from Kaiser Northern California, which is using the Kaiser data, looking, more back in time, because they have a, giant database, looking at comparing people who use cannabis during pregnancy. And I don't know how specific they are around for nausea and vomiting or not, but comparing those people to people who use prescribed medications for nausea and vomiting during pregnancy. So those are the two. They are, I think they're both R01, so these are 5-year studies. They're both, I think, in their first or second year. So it's going to be a while until those data are, matured and published and available. But those are the two that I know of that I think will really help fill in some of the gaps.
Wonderful.
The other dimension that you haven't asked about relates to breastfeeding. And cannabis and breastfeeding. So I do not know the status of this debate in Canada. In the United States, the American Academy of Pediatrics, as well as the American whatever it's called, Academy of Breastfeeding, it might be called, they both have issued guidance around breastfeeding, which more, or depending how you read the guidance, really state at least caution in recommending or encouraging breastfeeding amongst people who are using cannabis. The concerns include, transmission of metabolites in breast milk, as well as, second or third hand, smoke exposure to the infant. I would say these guidance documents, especially the American Academy of Pediatrics, are when you read them, relatively nuanced. But in practice, what this means is in many hospitals, if somebody tests positive at the time of delivery for, THC metabolites, they are literally, quote unquote, prohibited from breastfeeding.
Interesting.
Yeah, so there's, how I meant, so you asked about, racial inequities in child welfare. And I said that there's, some exceptions. And this is a story of an exception. It was a woman in Colorado who fell down some stairs during around 7 months pregnant, injured her back, went to the doctor. The doctor said, I'm going to prescribe you some opioids. This is about 5 years ago or so. She said, I'm not so sure about opioids. I've been hearing a lot of bad stuff about this.
You think?
She's in Colorado, which has already legalized cannabis. And she's like, I'm going to use cannabis. Unclear if she had used it before or not. So she uses cannabis, for her pain. Pain is better. At the time of delivery, she tests positive. She's prohibited from breastfeeding. The case goes off the rails. She gets literally court ordered to not breastfeed. Judges ruling that, you're in violation of the court order because you're breastfeeding. This is like messed up. This is,
Yes.
like misunderstanding, what the drug test is, misunderstanding what the data on, and even what the professional society recommendations are breastfeeding on, and a complete violation of this woman's, autonomy and, bodily integrity. So in practice, like, these guidelines have really confused providers, and it's not at all uncommon for people who use cannabis or people who stopped using, but the test is still positive because those metabolites stick around for a very long period of time, to be, quote unquote, prohibited from breastfeeding, reported to child welfare when they, take care of their kid in the way that we've been encouraging people for the right reasons to, in our support, public health support of breastfeeding and et cetera. To that, I will add, what we don't know, and Dr. Mark, who is going to be on this podcast, who's unable to be here, she has submitted a grant that did not get funded to look at this, which is, we don't know how people metabolize, cannabinoids in general, much less THC in pregnancy. And it's possible that the metabolites stick around a lot longer during pregnancy than they do not during pregnancy. And so our interpretation of what a positive drug test means at delivery is actually based on data from non-pregnant people, and is flawed.
So in review, because I think we're going to run out of time here with Zoom. In review, in your practice, in your research, looking at cannabis and pregnancy, there is nothing. How do I word this? The data's still out. We don't know. We can't correlate any direct causative harm to an infant and later in life. If we just look at cannabis.
Yeah, I would say, I'll phrase this slightly differently. The main risk associated with using cannabis in pregnancy is the fact that it is illegal, and, and even, so that you, have to engage in, an illegal economy in order to get the cannabis. 1, 2, you're not exactly always sure what you're getting. And that puts you and your family at greater risk than the chemical exposure does.
Just entering the illegal market is more risky than consuming it.
Yeah, because and in pregnancy, the main risk is child welfare. Being investigated by child welfare, having your kid replaced into foster care, and all of the nonsense and injury that comes from that to you and to your family. That is the greatest risk of cannabis. Is the social response is the greatest risk. The medical risk. Yeah, go ahead.
Well, I was going to let you, the medical risk, I should let you finish that one. Finish that thought, please. the medical risk?
So the medical risk is, is not zero, but the magnitude of the risk is likely low. It's confounded by other things. And so to me, what we want as clinicians and public health people is, to support people to, have the healthiest pregnancies possible, to raise their children, in safe, stable environments, devoid of violence. And so that means, one, making sure people don't have other conditions for which there's, treatment, i.e. addiction or, other diseases. And then really supporting people in the postpartum period. So I think, people who are healthy, have healthy babies and, have healthier families. And so it's about health and wellness, more than it is about, legal, illegal.
So let's think of utopia. Let's think of Canada. Utopia. So we have legalized cannabis medicine and recreational Canada. There is some thought that America is going to go that way in the next few years because of the economy it offers, right? So let's look at the utopian world that America is now legal for cannabis. So how does that change your practice and your recommendations to women? Do you think there's still going to be this social stigma? Do you think there's still going to be social services?
Yeah, I think it will depend. But I think clearly from the experience of states like Colorado, which have, legalized as much as they can at the state level cannabis, we still see, pregnant people are treated differently. Right? Both in terms of the breastfeeding stuff, in terms of especially child welfare. And that's an example, to me, that's when we treat people differently based upon, inherent conditions, i.e. pregnant or not, that's discrimination. So I think that just the simple legalization blanket, works for most people most of the time, but does not work in pregnancy. And so without specific attention to that, that sort of surveillance of, and the unequal surveillance that CPS child welfare does will continue, even under a regime of legalization. So that needs to be explicitly addressed. And the assumption that legalization will get rid of that is it definitely won't happen. So that stuff needs to be, kind of like, cleared up. Okay. In terms of, from the medical side of things, we will learn more, but to me, I think cannabinoids have therapeutic potential without a doubt. We know this from the historic record. We know this from recent data looking at, cannabis and, wasting and stuff like this. But I wouldn't call cannabis, a medicine in the same way that, ondansetron or Phenergan are medicines, right? So
why?
What we need and
why is it not medicine that way?
Well, because it's medicine in an old and I don't mean this at all as criticism, in a pre-modern way, right? It's plant-based and to a large extent, although this is changing, anecdotal. And that doesn't mean that it's wrong. It just means when we think of medicine in the United States, I think of, a chemical compound that is, studied in a randomized control trial fashion, explicitly reported.
Spoken like a true Western doctor. There you go. I was looking for that one.
Yeah, exactly. So that, and I think cannabinoids have incredible therapeutic potential, and we need to study them. And the United States, it's still, it's so hard to study cannabinoids. And there are cannabinoids in almost every single part of the human body except the brainstem, and there are cannabinoid receptors throughout the reproductive system. And there are, animal models of exogenous cannabinoids related to, miscarriage and stuff like that. So that even from a women's health perspective, I think there's, there's a great possibility of, medications in the future, and yet we can't really.
This is a whole new podcast. You just made a comment. Well, you just made a comment about the women's reproductive. There's cannabinoid receptor cells in the uterus and are these CBD1?
Oh yeah, fallopian tubes. Oh yeah. Mm-hmm. Yeah.
Are these CBD2 or CBD1 receptors, or are these?
I think they're. I don't know. I don't want to say the wrong thing.
Okay.
but I know that there are sort of animal models of miscarriage animal models that utilize exogenous cannabinoids that I think bind to both.
Okay.
I don't, but I honestly just don't know off the top of my head.
So here's a question, and I'll just throw it out there. If our body has these receptor cells, and we go back millennia where plant medicine was practiced, is there a future for cannabis as medicine for women's health? I mean,
yeah, I mean, I think that the historic record is so cannabis really is more described for women's health related stuff than any other medical condition historically. And that, I don't mean just through the, 150 years ago. I mean, like as far back as there are our pharmacopoeias. And so, yes, I think that would strongly, suggest, therapeutic benefit of cannabinoids through like this sort of modern, quote unquote, regimen. The fact that we have cannabinoid receptors is that, to me, the more similar substances are opioids that way too, right? We have opioid receptors and a historic, use of opioids, as far back as, there are, records of, to some, some parts of the world. And so, to me, those are kind of like sort of similar things. It's just that, we identified those compounds and isolated the receptor like a whole lot earlier for the opioid than we did for the cannabis. Yeah. And cannabis got, in the United States, at least, lost in, just the larger, war on drugs, prohibition, and has not really been adequately separated from that, despite, I mean, it's misclassified clearly. It's classified as something without medical benefit, which is that it's clear that there is the possibility of at least the possibility of medical benefit from cannabinoids. So that classification system needs to change in the States.
Dr. Terplan, I could talk to you for hours. I already have lists of others I want to talk to you about. Is there any question I should have asked you or forgot to ask you? Is there any topic you'd like to?
Oh, I mean, I agree. I feel like we just sort of skated along the surface, but that's not a criticism. But it's been a real pleasure. Thank you so much for inviting me. I don't have any questions at this moment.
Okay, Kirk, we're back out. So much going on there. I probably should listen to it a few more times. But one of the things, because it's come up other places, what is cannabis hyperemesis syndrome?
I've never seen it, but in the literature and I have talked to practitioners that have seen it. It comes when somebody is consuming a lot of cannabis to the point that their body starts rejecting it and they start vomiting, and they vomit aggressively, and it's very uncomfortable. And nothing seems to settle it. The normal antiemetics don't seem to help. So it seems to be out there, and I'm not sure if it's from too much ingestion or from smoking it too much. And
the interesting thing, I know you and Dr. Terplan didn't get in, and he would be into it, but there is a lot of nausea and vomiting in pregnancy is relatively common. And there's even a small, tiny minority of women who vomit basically uncontrollably during pregnancy, to the point that it's, unfortunately, vomiting during pregnancy, fairly normal. Vomiting to the point of we worry about the electrolytes of the baby, not, but, it does happen. And he was saying that cannabis hyperemesis syndrome does even happen sometimes in pregnancy. So, but on to the regular nausea bit, I thought it was fascinating that sometimes cannabis might actually make the nausea and vomiting in pregnancy worse. So what did you think about that bit?
Well, again, I enjoyed chatting with him, and it's funny being part of a conversation with somebody, and I'm trying to interview him, but as you can see, as the conversation started going, it just became a conversation, and there was some questions that I would like to have explored more. One that I found interesting was when it came right down to what he was saying is that we don't really know.
Yeah.
It goes it goes back to the conversation we had with COVID, the COVID episode. Cannabis can help the body, but a certain strain can also harm the body. So again, when it comes to cannabis, there's no easy answer.
No, because he did say that there are some people that the cannabis actually helped their nausea and vomiting during pregnancy. And there were some that it didn't, some that it made worse. They think some of it had to do with whether or not you're cannabis naive. If you're cannabis naive and the first time you tried it was during pregnancy, might not be, but if you weren't, it might. Why I'm harping on this is we have a pill called diclectin that we give to women when they're nauseous in pregnancy, and it's good.
And it works really well.
Well, here's the problem. There are people, even this standard drug, that is its indication. It's not involved in pregnancy. There are researchers who would argue up and down that it's frankly no better than a placebo, because the whole nausea and vomiting in pregnancy is so hard to pin down what's causing it, what's not. Just because you're nauseous this week in your pregnancy doesn't mean you're nauseous that week. And if you happen to have taken this diclectin in between, you think that diclectin is the best thing ever. And so it was funny. It just reminded me using and I'm not saying that cannabis is better or worse than diclectin, but it just reminded me from some of the readings we've done over the years on diclectin is it helping? Is it not? We don't really know.
Isn't that interesting? So once again, medicine can be seen as hypocritical. So we'll give somebody a pill that we think might work, but we got studies that say it doesn't work. But cannabis can't use cannabis.
Yeah.
And this is the part of the conversation I enjoyed with Dr. Terplan was essentially how he wove into his story is that we don't know a lot about cannabis, but what we do know about cannabis is it doesn't seem to do a lot of harm.
No.
And it seems like and that's another theme that sort of you can weave in all of our episodes when we've talked to experts, right? Experts of cannabis, this new plant that's been around for 5 years or 20 years in Canada. It really doesn't do much harm.
Well, and he had many sort of mind-blowing statements. One, because, pharmacists, I talk to pregnant people about we'll call it drug use, but I'm talking about like medication, all the stuff they put in their body during pregnancy.
Yeah.
I talk about that a lot. And he kind of blew my mind with the no substance of abuse other than alcohol is teratogenic. Now, teratogenic it means causes a birth defect.
Yes.
We throw that around in pharmacy world a lot. Teratogenic is bad, causes a birth defect. So think thalidomide with the stumpy arm thing. That's right. That's the archetypical teratogenic. My apologies to anyone with
if anybody sees the video, that was very visual.
but that we talk about, I have people who come into the pharmacy who use meth, who've used cocaine, who've used and we worry, and some percentage of them get pregnant because they're people and people get pregnant. So we worry about all those things affecting the kids.
You have crack babies
Right. But and I'm not saying it's good if you are but remember in the 80s we talked about crack babies. That was literally a term.
Yeah.
But he's right. Now I'm not saying it's good. Don't get me wrong, but they certainly weren't born with 3 eyes.
Yeah.
So it's just
the
things we're really afraid of maybe aren't as bad.
Yeah. Well, it goes right back to prohibition, man. Prohibition of all drugs, and are drugs a crime or are drugs a health issue? So this doctor, he works with addictions, and you'd think he'd know, right? He's seen it. So again, how does it affect my practice as a nurse when I'm dealing with prenatal patients? And I do have active prenatal files where I work. It's good insight for me to, the whole fear thing. If you're going to do cannabis, probably shouldn't, but, alcohol or cannabis, harm reduction. Again, I don't want to get myself in trouble. The best diet is a balanced diet, no drugs. But harm reduction, right? Nursing is all about harm reduction. Cannabis Well, don't really think it does a lot of harm.
Well, and for the stuff that does do harm, you're talking about prohibition.
Yeah.
His crazy story about, so a lot of U.S. hospitals, I'm sure this happens in Canada too, but he's in the U.S. So the hospitals routinely test for cannabis and cannabis metabolites when women give birth.
Yes.
So they tested it for this one woman in particular in a legal state. She started using it under a doctor's direction for a back injury while pregnant.
Yeah.
They found metabolites. She said, yeah, of course, I'm using it medicinally. And because of that, they wouldn't let her breastfeed.
Yeah.
Now, Kirk, you do way more breastfeeding talking than I do. Kirk, is breastfeeding good for babies?
It's the best for babies. It's the best. I mean, I'm not a nipple Nazi, but breastfeeding, it's the best. It's
breastfeeding, real good for babies, right?
Real good for babies. Yeah.
So the idea that you would not let a baby suckle from a mom who has some cannabis metabolites just kind of blows my mind.
Yeah. So again, it's the harm reduction, right? So obviously cannabinoids are found in breast milk. So how is that going to affect the baby? Now here's the question I have. The stuff in cannabis that is in the breast milk, is it THC? Is it CBDs? What is it? I mean, I don't know.
We don't know, and he made that point. We know so little about the metabolism of cannabis that we're not even sure whatever cannabinoid it got turned into, what it does. Like, it's a little bananas that we don't know the effect of the metabolite, but we know for sure it's terrible for the infant.
But do we? Because all the studies, when they start looking at the studies and start breaking down the factors and the causative effects, and you isolate cannabis, well, we really haven't seen it do too much harm. We don't want people doing it because we don't understand it. But as you said, we'll give them a medicine that we know doesn't really work because it works for people. So I don't know, Trevor, it's all so wild. And his enthusiasm for wanting to study cannabis, I bonded with him because it's,
definitely infectious. Last of his, he had many more mind-blowing things, but last of his mind-blowing little quotes that I just wanted to pull out, because I had no idea what the numbers were. I like numbers. So he said, okay, so best as we can tell, birth weight reduction with cannabis, 25 to 50 grams.
Yeah.
Okay, so I hear that, go, okay, that sounds significant. You say, yeah, we can find that. That's statistically significant, so a real effect, not just by chance. So, okay, no, that's all right. We should be concerned about that. Pharmacist goes, yeah, that sounds. And they said, but you do have to, if you compare that to tobacco, 500 grams less, like a tenfold more likely to cause harm with tobacco.
A half a kilo, right?
Well, it's a pound. It's a pound.
Yeah.
For people who think in pounds, 454. But 500 grams is a pound. You weigh a pound less at birth. And nobody yanks the baby away from, I'm not saying it's good, but no one yanks babies away from smoking mothers.
Yeah. It's the cannabis stigma, right? It's back to that whole stigma, cannabis stigma. And it's and this is why I wanted to do this series. I want to investigate this more in regards to how doctors are looking and nurses and how we're looking at cannabis for the health of people, right? So series on prenatal exposure to cannabis, episode 2, I guess.
Yeah, no, I was a little leery when we first started the series, I'll be honest, because I didn't want us to sort of go over the edge into saying things that are going to get us professionally in trouble, but this has been way more interesting and enlightening than I ever thought it was going to be.
Well,
all right, Kirk. Again, a fascinating look. Dr. Terplan, thank you very much.
Yes. Music. I got to get back to him. He said he would give us some Turkish stuff from the 70s.